so we'll go ahead and get started. Welcome everybody to the St. Paul's and Vancouver General Hospital Grand Rounds for the Division of Allergy and Immunology. I'll start with a land acknowledgement. So we acknowledge today that we are gathered and are grateful to live, work, and play on the traditional, ancestral, and unceded territory of the Coast Salish peoples, including the Squamish, Tsleil-Waututh, and Musqueam nations, and ask those not on these lands to reflect on the territories that they are currently in. And so it's my absolute delight to welcome Dr. John Hsi-En, who's going to be giving grand rounds today. And just a little brief bio about Dr. Ho. So he received his medical degree from Yale School of Medicine and completed his internal medicine residency at Beth Israel Deaconess Medical Center in Boston. He then pursued combined adult and pediatric allergy immunology fellowship training at Mount Sinai in New York City, where he is now an assistant professor of medicine and associate director of the primary immunodeficiency program. Dr. Ho is a clinical immunologist whose work focuses on primary and secondary immune deficiencies, and he leads translational studies and clinical trials for patients with atopic and immunological disorders. And to provide some additional context, when we think about immunology in the adult population, common variable immunodeficiency is the most prevalent condition that we diagnose and manage, and comes with a lot of challenges. And when we think about CVID, the sort of global experts on this is the program at Mount Sinai that Dr. Ho is an associate director of. And so these are the colleagues that we go to. They take care of the largest cohort of CVID patients. And so we've been very grateful to ask Dr. Ho's advice for the patients that we see here. And it's just amazing that he can come and visit and share his knowledge with us. So thank you so much for making the effort to come all this way. And we really appreciate it. And we're excited for rounds today. And then next week is the Division of Critical Care, Dr. Boyd. Yeah.
Thank you so much, Dr. Biggs. So hi, everyone. Thank you for a kind introduction. The background is Dr. Biggs and I actually went to the same program at McGill as an undergrad. And so it's kind of nice that, kind of full circle. Again, thank you. It's such a privilege to be here at St. Paul's Hospital and have the opportunity to speak with you guys. I grew up in Ontario, did my undergrad here, so definitely feel a moment full circle to be back in Canadian academic setting for grand rounds. And so thank you so much for the invitation. These are my disclosures. I will briefly touch upon some off-label therapies near the end of my talk today. So just so I know the audience, everyone here is mostly internal medicine, right? And residents mostly? Okay, cool, okay. So my goal today is to help you understand how immune defects can present, and it may not be exactly how you'd imagine based on medical school knowledge or even medicine boards. We'll also review what's new in the field to help you take care of some of the patients that may show up in your clinic or maybe are already in your clinic already. So starting with the case, this is a 40-year-old high school coach who presented with fever and cough for a week. In the ER, he was tachycardic, had a temperature and slightly elevated white count. Chest X-ray showed pneumonia and a rapid up low, and his viral swab was negative. So, we've admitted or seen patients with pneumonia, pretty much all the time. It's one of the most common reasons for admissions. And many of us may even have a smart phrase for it in the computer. It's becoming really routine for us. We'll start these patients on antibiotics. We'll see whether they need to be admitted, get culture. Thankfully, most of the time, they do really well. For this guy, however, if you ask him a few more questions, he actually had another pneumonia earlier that year, and he also reported a problem with recurrent rhinosinusitis. So his doctor thought that was kind of odd and sent him to Allergy, initially more for rhinitis evaluation. And his allergy workup was negative, but when they sent antibodies, he barely had any antibodies in him. His IgG 100, and normally it should be at least 600 to about 1400. Now, he actually was relatively lucky in terms of his quick diagnosis and recovery. This is another patient of ours, and he presented much more severely with empyema, culture grew strep pneumo, and he ended up needing prolonged chest tube drainage and decortication. This was his chest CT, so you can see it was rather dramatic. One side of his lung was completely wiped out, And it's perhaps not too surprising if you take a look at his antibody levels. His levels were even lower than our first patient. So I thought today, instead of one long talk, I'm going to split into a few mini ones, as I feel like with like TikTok and YouTube Shorts, our attention span is super short these days. So with a few mini talks, hopefully, we can, come up with a few key learning points that are helpful for you moving forwards. So let's talk about what we learned in med school. I think for most of us in internal medicine, this is the extent of our knowledge for immunodeficiency. It's basically 1 or 2 pages from the step 1 prep book if you ever take the US step exams. And when we think about immune deficiencies in med school, I think this is what comes to mind, cases like the bubble boy. So his name was David Vedder, and he was born in the 1970s with severe combined immune deficiencies. And he basically did not have a functioning adaptive immune system. And unfortunately, they couldn't find a bone marrow transplant match for him. So he lived in a bubble for 12 years. It was rather a heroic effort down in Texas. They set up a very sophisticated filtration system for him with a few different rooms. They actually even set up a spacesuit for him so he can go outside and play once in a while. When he was 12, he finally received bone marrow transplant, but unfortunately, he got exposed to EBV in the process and then developed EBV lymphoma a few months later and passed away. So I think it's easy to mistake that immunodeficiency is mainly a pediatric issue, which is why I think me included, when I was in residency, I didn't really think about immunology on my differential. But I think it's something we need to change our mind about, because in reality, this is not the case. So if we take a look at primary antibody deficiency, for example, which is the most common immune defect, the median age of reported symptom onset is actually 20, and the median age of diagnosis is 35 years old, which is squarely in our medicine arena. And as you can see, there's unfortunately very long diagnostic delay, usually around 9 to 10 years before people start to think about, hey, maybe there's something wrong here. We need to look in further. So why is this important? I think this misconception and diagnostic delay has a big impact for the patients. So this is one of the patients that showed up in our adult immunology clinic. When he first received medical help, he was only 20 years old. He was actually climbing up ladders at work, and he couldn't even make it without being out of breath. By the time he made it immunology, he was in his mid-20s, and we found that he has very severe antibody deficiencies. And I think it's kind of sad when you look at his chest CT, you just kind of know that his lung is not going to last longer for him. It's already scarred so much from recurrent infections, and then he will be needing transplant sometime soon. So imagine if someone checked his antibody levels even later, his lung damage would have been even worse. So I think immune deficiency is something important we should keep in mind as internists. Now, as a quick refresher, how do these immune deficiencies classically present, at least in textbooks? The most common category is antibody deficiencies. Classic presentation is cytopulmonary infections. The typical bacteria we see are Strep pneumo, Haemophilus. It's kind of interesting that it's so frequently these bugs. I think our antibody is just so important in targeting and recognizing the polysaccharide capsule and get rid of this bacteria for us. A side note is that they're also susceptible to GI infections, which can be really chronic. The most well-known condition in this group is called common variable immunodeficiency, or CVID. But in addition, IgA deficiency is actually very common, affecting about 1 in 200 individuals if you come from certain Northern European ancestry. So many of these patients are asymptomatic, while others can present with a milder phenotype along this same spectrum. So this is something that you will encounter in your clinical career and clinical practice. Just a quick review. The second big category are phagocyte defects. The most well-known one in this group is chronic granulomatous disease. It's a condition where neutrophil basically cannot make enough superoxide, basically bleach. This patient can develop soft tissue or deep organ infections. So this patient here had a deep abscess in his liver. We had one patient who ended up growing fungi from brackish water in his leg muscles, and ended up needing amputation. So it can be quite severe. They can also get pneumonia or osteomyelitis. And the typical pathogens are Staph aureus, Aspergillus, Burkholderia, Serratia, Nocardia. So if you're ever on the floor, you see a deep organ infection with one of these bacteria or fungi on the floor ICU, definitely worth to think about immunology and get the team involved. The third classic group is T-cell defect. I think a lot of us know pretty well from perhaps our oncology patients. This patient will suffer from opportunistic infections, fungal infections, persistent severe thrush, and sometimes even life-attenuating vaccine. So if someone's born outside Canada and had BCG vaccine, sometimes it can make them really sick as well. All right, so we're done with 1 minute talk. For the second minute talk, I titled Side Door, Back Entrance, and Secret Elevators. So what do I mean by that? So I think most people don't realize what immunologists do or see, or may not even know that we do exist. So I think most people's mind would probably like hidden away in an attic somewhere, maybe in a hammock, reading some immunology book, thinking about immune cells. I think most people realize it might be kind of hard to get to our subspecialty. But I think in general, how do people get to us? If you have a very good general practitioner, family physician, that's the most direct way to get to us. If they start noticing you've been getting sick a lot or getting some unusual infections. We also tend to get a referral from our infectious disease colleagues when they see really severe and really strange cases. But I think the reality is that a lot of these patients are actually hidden elsewhere in other specialty. Some of them are specialty that you may want to go into. So we actually get them from hematology, rheumatology, and GI clinic. And then there are some really unusual backdoors to get to immunology. Once in a while, we will get a very astute pathologist who never saw the patient, but they'll look at your slide and say, hey, one type of immune cells are not there at all, and they'll trigger a consult. So we have a patient who had their life saved because of a pathologist they've never met before. So let's go through a few examples. So in case anyone's going to hem on here, so in a hematology clinic, for example, we'll know about Evans syndrome, autoimmune hemolytic anemia, ITP, immune neutropenia. A few years ago, a group of physicians decided to take a look at the patients who have symptoms since they were young and see what's going on in this population. They ask, do they just have Evans syndrome, or do they have something else underlying their hematological condition? They went and sequenced the genes of these patients, about 80 of them. And interestingly, at the end, 65% of them actually had an underlying genetic mutation that leads to inborn errors of immunity that they were born with. I put a list here not for you to go through them, but more give you a sense of variety of what it could be underneath. And when the physicians took another step back, they found that autoimmune condition actually occur 80 times more frequently in the primary immunodeficiency population than age-matched control for things like ITP or hemolytic anemia. And the risk factor is actually even higher, about 120 times more if the symptom onset was during childhood. So I think it's pretty dramatic numbers, and it would demonstrate that we should not only think about infections when we think about primary immunodeficiencies. They actually can present quite differently. Let's take a look at common variable immune deficiency, for example. Again, it's the most common immune defect. It's a condition where basically your B cells don't mature properly and they have very low IgG and other antibodies overall. And if you look at this profile, most people would think that infection and pneumonia is the main problem. But is that true? So as Dr. Biggs mentioned, we're lucky to have this biggest cohort of these patients in New York. So I took a look at this back in 2020 and asked, are infection their main problem, or do they have something else that's really affecting their lives? And so while infection is certainly a big part of the story, what we found was that it's only one piece. So about 70% of the patients actually develop chronic inflammation and autoimmunity affecting different organ systems. So a third of them have interstitial lung disease, and beyond that, we see enteropathy, hematologic diseases, liver disease, as well as increased risk of lymphoma. So nowadays in my mind, I don't think of them as immunodeficiency anymore. I think it's more accurate to think of them as immune dysregulation disorders. So how about in a GI clinic? What happens if we focus on patients who has had IBD since they were young? So, or they have very severe disease that's difficult to treat. So this is typically defined as disease presenting before the age of 6. When this group of doctors applied the same genetic sequencing approach, they found that this group also give a very high yield for underlying primary immunodeficiency. And clinically, this patient also tend to look a bit different, not just the classic IBD, but they may have some additional atypical feature. So for example, they have more severe systemic autoimmunity, or they may have a history of unusual infections. So, and why does this matter? Because I think it can actually fundamentally change your clinical management. It may influence which biological therapy you choose and how you weigh the risk of infections against the benefits of immune suppressions. In some patients, this also opens doors for additional interventions, such as antimicrobial prophylaxis, or you can start them on immunoglobulin replacement if they have antibody defects. And I think select cases identifying the underlying defect can also point towards targeted mechanism-based therapies. So for example, we have identified a patient with what's called CTLA4 deficiency, and there's a medication called abatacept that can specifically address this immune dysregulation. And then lastly, this is what I was mentioning, it's kind of interesting. So this is an example of referral from pathology. So this is a pathologist who was looking at a case of difficult to treat IBD. And when they stained the gut tissue with plasma cells, they couldn't find any. So refer the patient to us. And in fact, they actually have CVID rather than just IBD alone. All right, so hopefully that was painless so far. So for the third mini talk, what I want to share is the concept that each infection we experience actually tells us something about our immune system, and that it often comes down to our genetic susceptibility. So sometimes we can blame on our parents. So, we've all been sick, right? All of us have gotten cold at some point, and we have admitted patients with infections pretty much all the time. But if you have a quote unquote good immune system, what's supposed to happen is you recover from the illness. And if you encounter the same bacterial virus again, your immune system will remember it, and most likely you'll experience a milder disease, or you may not even have symptoms at all. But one of our collaborators at Rockefeller University asked an interesting question. How about those patients who are more rare, but when they get sick, they end up in a hospital in the ICU? What's going on there? And some patients have even passed away from infection that wouldn't affect you and I on a day-to-day basis. They asked, do they have some underlying immune deficiency that we should have known? So let's look at what they found. So this is mycobacterium infections. I remember I used to do a lot of TB rule out admissions, which are always kind of slow. But what if you start seeing unusual organisms growing on the cultures, like some of the mycobacterium that you were not as familiar with? A lot of these patients are otherwise healthy, but they become disproportionately sick when exposed to mycobacteria. And in the places where BCG vaccines use, some can also develop very severe systemic disease from them. And this doctor took a closer look at these patients. They sequenced their genes and found something interesting. When the cases were brought together, there was a clear pattern, and it made biological sense. So these patients all have genetic defects affecting the interferon gamma production pathway or signaling. So as we know, interferon gamma is central to our defense against mycobacterium. And so now this group of disorders is known as Mendelian susceptibility to mycobacterial diseases. So if you ever encounter very unusual or severe mycobacterial infections, it's worth it to think about this as on your differential. This is another interesting story. I kind of brought it up because I was born in Taiwan, and I think it's like the one paper from Taiwan that's in New England Journal of Medicine. But it was a group of doctors from Taiwan and Thailand who noticed a cohort of adult patients who don't have HIV, but are behaving as if they might. These group of patients, they are mostly middle-aged, but some as young as 18, some as old as 78, slightly more skewed towards female, and they all suffer from disseminated disease from environmental mycobacterium or severe opportunistic infections, and predominantly Asian, which is probably some genetic background there. Most of them have previously been healthy, no prior history of unusual infections. So when they sequenced their gene, they didn't find anything. So a lot of doctors just think, maybe they were just unlucky. They caught a very bad strain, and it is what it is. But this doctor decided to take a look further. They decided to start measuring autoantibodies because these are a group of older patients. And what they found was that instead of a genetic defect in the interferon gamma production, this patient actually developed neutralizing autoantibody against the cytokine interferon gamma over time. So rather than having a primary immune deficiency, this is an acquired autoimmune process that mimic primary immune deficiency and onset later in life, which makes sense. As we get older, our risk for autoimmune disease tend to increase. So we now call this phenocopies of inborn errors of immunity, essentially autoimmune disease that present like an immune deficiency. And this concept extends to several other conditions now as well. For example, there's a defect that leads to chronic mucocutaneous candidiasis. Basically, they have horrible infectious thrush in different areas of their body. But a similar phenotype can also be seen in patients with autoimmune disease, such as there's something called autoimmune polyendocrine syndrome. So in these cases, the patient also develops autoantibody against a cytokine, in this case, IL-17, which is very important for antifungal defense. And so rather than having isolated autoimmune issue, this patient also gets susceptibility to infections. And I think these insights have important implications as well for biotech and pharmaceutical industry. There are more and more immune-targeted therapy available nowadays. So for example, now we use IL-17 for psoriasis. So this group of patients actually can provide valuable insights to potential side effects that we need to watch out for when we block certain parts of the immune system. And this is a table to summarize this group of disorders. So if you're getting mycobacterial infections, non-typhoid salmonella, you might want to take a look at autoantibody against interferon gamma. If you're getting cryptococcus or nocardial infections, you might want to look at autoantibody against GM-CSF. And if you have very severe or unusually invasive staph infections, some might want to take a look at autoantibody against IL-6. And this is the last part for this section. I won't go too much into it because I think all of us remember this pretty well. This concept actually applied to emerging pathogens as well. If you think back in early 2020, it really did feel like a roulette, right? You see people, sometimes they catch COVID and they're completely fine, but you hear in the news that someone in their early 30s got COVID, was in the ICU, and start thinking to yourself, oh, I'm in my 30s, what's going to happen to me? And what we've since learned is that among younger people who became severely ill from COVID, up to 5% of them have underlying inborn errors in type 1 interferon pathway, which is important for antiviral defense. And if you're older, a significant portion, about 20% of them, actually have autoantibodies against type 1 interferon, which impair the same pathway and predispose them to severe COVID. So again, it's the exact same thing, whether genetic or acquired. We see that disruption of this pathway can shape the outcome, not just for rare infections, but for day-to-day infections that we encounter all the time. Now, everything we talk about have largely been in the context of what we traditionally think of as primary immune deficiency or naturally occurring phenocopies of it. But I think increasingly, you guys will probably have seen a lot of this here as well. In medicine today, we're creating these phenotypes ourselves. And that brings me to the next section, secondary immunodeficiency. In particular, what we're seeing with newer therapies that deplete specific immune cells, and in doing so, creating new immune vulnerabilities. So these are the surface proteins that are expressed at different stages of B cell development. So classically, we just use this to mark the B cells. The hematologists will use it, pathologists will use it. But in the past decade, what we realized is we can use them as effective target to eliminate specific group of cells that can cause cancer or autoimmunity or other immune dysregulation. So previously, we used our monoclonal antibodies like rituximab that target B cells often temporarily. More recently, we've entered an era of much more potent immunotherapies. So this includes CAR T cell therapy or T cell engagers, such as bispecific antibodies. And they're very, very good at depleting specific cell population, particularly B cells and plasma cell precursors. And not surprisingly, we're now seeing much more profound and prolonged immune deficiencies, including sustained B cell aplasia, plasma depletion, and all lead to severe hypogammaglobulinemia. This is definitely an actively evolving field, but here are some of the key data so far. So we know that if you give patients anti-CD19 CAR T, hypogammaglobulinemia is the most common on target of tumor toxicity. So from this, up to a third of patients will experience severe infections. If you are targeting BCMA CAR T, for example, in multiple myeloma, if the presentation is actually even more severe, up to 68% of them will have persisting hypogammaglobulinemia. And how much IgG drops in your body before and after treatment actually predict your mortality risks. For bispecific antibodies, like for example, CD20, CD3 engagers in B-cell lymphomas, what we found is that, at least 76% of them will have infection within the first 2 years. And the IgG level is actually the main risk factor for predicting severe infections. And not just oncology. If you do a quick Google search, there are now more than 200 clinical trials in development to harness this technology for autoimmune diseases in like rheumatology or neurology. So frequently, we're now seeing referrals for patients with baseline immune dysregulation or autoimmunity who then receive various anti-B cell therapy and have low IgG. And so for patients with baseline autoimmune disease, one frequent patient that then come up is, did they have some underlying immune disorder to begin with, or are their symptoms all secondary to anti-B cell treatment? And this is actually a very tough question to answer, especially if there was no baseline immune workup before the immune targeted therapy was initiated. So it's often difficult to decide chicken or the egg, one or the other. And I think you could argue that it doesn't matter, if they have antibody deficiencies, you just treat, right? But in practice, we have found that it often matters to the patients. A lot of people want to understand whether there's something they should anticipate lifelong, or for some, or is it just due to the treatment and just temporary? And for others, it's actually very important for family planning if they plan having kids. If it's genetic, it's something that they can pass on to their children as well. And clinically, it's also quite actionable. If you're admitting a patient with recurrent or severe infection, and you saw that they had, maybe rituximab or some other anti-B cell therapy from a few years ago, I think it's worth checking their IgG level, and identifying a persistent antibody deficiency can meaningfully change management. And I think in many cases, make a real impact for the patient. And so I think this is a rapidly changing field, but there's a lot of guidance we can learn from the primary immune deficiency patients and literature. And first, even just understand the immune targets. So for example, actually not all these patients will require IVIG or IgG replacement. So if you have a CAR T cell therapy or bispecific antibody that targets CD19, actually a lot of plasma cells don't express CD19. So when you think about it that way, a lot of these patients will actually retain some level of IgG production themselves. But if someone got like an anti-BCMA, which target more the later stage of B cells, those patients tend to be a lot more severe. and have a lot more antibody depletion. I also think it's going to be more and more important to consider the underlying disease state. So if you have a B-cell lymphoma, you get anti-B cell therapy. I think that's very clear cut. But if someone has underlying autoimmune disease or immune dysregulation, it might be more difficult to tease out what's going on here, and how you treat the patient will be different, because it may not just be the B cell that's in problem. It might be other immune cell type that was already misbehaving. And I think what's actually interesting is that a lot of things that we use now for CAR T cell, the targets CD19, CD20, BCMA, they're actually patients who are born without these proteins. So they're kind of already providing us with a roadmap on how to manage how they may present and how we can go about treating them. So I think there's a lot of pre-existing literature that we can rely on, and there's a lot of interesting discussion between immunology, oncology, and rheumatology as well, especially when it comes out to when do we treat, how often to treat, how to treat their antibody deficiencies. All right, so this is the last segment. I think we have time. Yeah, okay. So one thing I've learned since becoming immunologist is that you really only find something when you think of it and when you look into it. So I'm in New York City right now. It's right in the center of 20+ million people. And one time last year, I saw a sick patient in a hospital. And after we explained his complex immune conditions, we asked him, what kind of questions do you have for us? And his only question for us was, doc, when can I go home? He was really worried about losing his job, his social income, because of his prolonged hospitalization and sickness. So I think many people may not have the socioeconomic or time resources to really seek out the Uber subspecialist like me. And so what can we do about that? This is a study that we did many years ago. We used hospital admission codes and weighted them for infections that might suggest an underlying immune defect. Things like deep organ infections, brain infections, sepsis or pneumonia. We then exclude patients with obvious confounders, so HIV, cancer, transplant, or major surgery. And what we left at the end was 533 patients who accounted for disproportionately high number of recurrent infection-related admission. So just 500 patients accounted for 2,500 admission in a short period. And we asked, what's going on here? We set up an outreach program and invited this patient in for immune evaluation, essentially saying, you've been getting sick frequently and severely. You may want to check this out to see what's going on. 59 patients ended up coming in, and the yield was quite high. About a third of them were found to have a primary immune deficiency, most commonly antibody defects. And about 1 in 5 had a secondary immunodeficiency. So they got rituximab maybe 8 years ago, but no one ever bothered to check or follow up on them afterwards. So, and almost 90% of them were actually from the underserved population in New York City. So now the technology are much better. I'm kind of sick of hearing AI every day, but we're very excited to use AI to see are there better way to identify these patients and enhance this program to outreach to them. So now one of the most common questions I get from other specialty is, when should I actually think about immunologist? If you look online, there are often these checklists, things like, if you get 5 sinus infections a year or 3 bronchitis episodes and so on and so forth. I think personally, I don't think that they're super helpful. I think my experience so far as immunology is that you should really keep an open mind. For me, I think the most helpful way is thinking about severity and how unusual it is. So if you see someone who has unusually severe infection, like there's a common cold in the ICU, and you're like, hey, that's kind of strange, worth getting us involved. Or if you see someone who just have a very strange bug, that even the ID doctor was like, oh, I haven't thought of that before, really, you might want to get immunology involved as well. And sometimes, even if you're not sure, we're happy to take a look And even if you think this is an unlikely immune deficiency, sometimes just like if it's just very strange, taking an extra look may just change someone's life forever. This is a patient I got a few years ago. It was a 26-year-old guy, just very severe whole body rash and recurrent skin infections. His quality of life has just been terrible for a long, long time. And this was his story. He was adopted, so he doesn't know what got passed down in his families. But, he used to be very active, but in the teenage years, he started to get very severe joint pain and stiffness. And at one point, he was actually in a wheelchair because he couldn't walk. And at age 14, he had more severe arthritis flare, very bad rash. And at the same time, he get a lot of infections, folliculitis, MRSA skin infections. They even try isotretinoin, and which actually made his symptom worse. So basically, all his teenage years up to mid-20 for 10 years, he was just going through different, very strong biologics, and none of them have helped. And finally, when he was 26, and this was kind of amazing, kudos to this person, he went to a dermatologist who was thought, this is kind of weird, why is he was labeled as eczema or psoriasis. And she thought, why is it so hard to treat? I never thought I was seeing this, but a dermatologist decided to sequence the genes of this patient. And what she found was something called SOX1. And she was like, what do I do with this? And then send the patient to me. And interesting, just a few months before this referral, there's a paper published on SOX1 mutation for the first time in the literature. And this is kind of nice. I definitely feel very privileged. We have a big team of clinicians, basic scientists, and geneticists. So I got the team assembled, the Avengers assembles, and be like, hey, we have these patients. What can we do? Is this SOX1 mutation real or not? So what is SOX1? Taking a step back. So our body have something called JAK-STAT. If you remember med school, it's a signaling pathway. I kind of think of them as traffic lights. So it's a green light or red light to see whether the cell should be activated or not. And SOX1 is kind of like a brake. So you can imagine if the brake is not functioning, then everything's green light and everything's hyperactive. So we felt that, hey, this might be what's going on in him. That's why he has so much hyperinflammation. So thankfully, one of our collaborator, Dusan, his lab was very interested in JAK-STAT. So in the tissue culture, they recreated his mutation and see how those cells were functioning. And I know it's a clinical setting, we're not going to go too much into it, but what they found was indeed that this is his mutation, that his SOX1 protein was not working properly. So how is this helpful for the patient or for anyone for that matter? What can we do about that? At that time, actually, this happened in 2021. So it was very sick, but we didn't know what to do. There's JAK1 inhibitor, which would be the most direct treatment, right? Because it basically acts as a brake in a similar pathway, so we can stop his inflammation. But I think the family was also right in worrying that, with COVID going on around, are we going to trade one problem for even worse problem? So we went back to the lab and we think about, hey, JAK-STAT is very important for what? And it's actually very important for cytokine signaling, which is how your immune cell decide whether to become activated or not. So for example, eczema is a lot of IL-4 inflammation, which is why we use dupilumab, right? And we also use dupilumab for asthma. And whereas some arthritis, IL-17 is very important. So we measure those cytokines and turned out that his IL-4, IL-17, this two particular cytokine was sky high. So we thought, JAK inhibitor may be too broad. What if we just block the relevant cytokines that's relevant to his end organs? So let's end up what we exactly did in the end. So we gave him, end up giving him Dupixent, anti-IL-4, anti-IL-13, and also gave him anti-IL-17. So this was before, and then this was a few months after. So it's very, very gratifying And it's actually kind of hard to get him back to the clinic now. He's doing really well. So I ended up sending him a my chart message last year. I was like, "Are you okay?" And he said, "Yo, my joints are great. Feel free to show anyone this follow photos." He was so nice. He said he did a complete 180 from a very low point in his life, and thanks to the team. And now he's actually doing CrossFit from having a lot of like joint pain and wheelchair to doing CrossFit. So it's pretty amazing. So I think a lot of times, even if you're not sure, if you think something's strange, we're happy to be involved. And I think when you kind of have a nice team, which there's also a very nice, really good team here at UBC, that you're not just helping the patient, we're actually just learning important biology. And a lot of times this actually feedback into our understanding of the immune system and future therapeutic development and clinical treatment strategies. So, honestly, I look back sometimes when I was in resident, when I was on night float, we did a lot of pneumonia admission. And honestly, we go from one patient to the next, especially on a busy night. And sometimes I wondered, did I miss anything? I've definitely admitted a patient who, this was the third pneumonia, should I have checked an antibody? So, last year, actually, I had a Down syndrome patient that came to me. He was mid-30s, 3 pneumonia every single year, lots of healthcare utilization. And everyone just chucked it to the fact that he has Down syndrome, maybe his hygiene is not good, he lives in a nursing home, that's why he's getting sick. And it was actually a sleep medicine doctor who just decided, hey, that's too many, let's check an IgG and check his B cells. And he didn't have any B cells at all. And I didn't know this before, but Down syndrome patient actually had variable degrees of immune deficiency. Not all this severe, but some of them can have some immune defects. So, I highly encourage everyone, the next time you do a pneumonia or infection admission, maybe not just, have a smart phrase, but smart stop for a second and think why. Why are they getting sick? And sometimes you may just change someone's